Hello class, Dr. Mike Burford here today talking with you about neurocognitive disorders. And I want to remind you as always that information for this lecture and the slides that you'll see on D2L comes from the DSM-5. So in terms of standard practice in neurocognitive disorders and any of the disorders really, I wanted to give you some information that I realized recently that I had neglected to mention. Generally, medical problems causing symptoms and questions should be ruled out by a healthcare professional, whether it's a physician or a nurse practitioner, physician's assistant, that kind of thing. And if you think about it, it makes sense. I mean, if we're going to try to look at somebody's behavior and emotional state, we want to before trying to provide diagnosis, make sure that their condition isn't the result of some kind of physical malady that's different than a mental disorder. Now, I want to caution you with that too, though, because as you may know by now, hopefully you know by now, some of the disorders in the DSM are related to medical problems. As a real quick example, I can tell you that problems with thyroid, the thyroid gland can cause mental health issues. And I also want to let you know that our subject today, neurocognitive disorders, have underlying medical problems, substance intoxication or withdrawal or toxin exposure. And so our disorders for today all have an underlying medical problem. Okay, so let's look at basics of neurocognitive disorders. There's a primary clinical deficit in cognitive functioning with these disorders, and they are differentiated from other disorders that have cognitive deficits. And cognitive impairment is acquired. It's not present at birth or at an early age in these disorders, and these disorders represent a decline from previous functioning. And unlike most illnesses, other illnesses anyway, in the DSM-5, underlying pathology and etiology for neurocognitive disorders can often be determined, which goes along with what I was saying earlier about underlying medical conditions. And it's also possible for several neurocognitive disorders to coexist with one another, and in fact it's suggested that frequently that's the case. I want to clarify a point that I spoke about just a minute ago. With these particular disorders, the core feature is a cognitive deficit or cognitive deficits, and that's what helps distinguish these disorders from other disorders, the neurocognitive disorders from other disorders. Okay, so when we're thinking about neurocognitive disorders, we need to consider the following domains. Complex attention is affected oftentimes. And when we say complex attention, we're thinking about sustained, divided, selective attention, processing speed, and those kind of things. We also think about the domain of executive functioning, which of course has to do with planning and decision making, working memory, responding to feedback, and mental flexibility. Another domain is learning and memory. Another one is language, expressive and receptive behavior. Another one is language, expressive and receptive language. Perceptual motor skills are sometimes affected. And social cognition, recognition of emotions, for instance, may be impaired with these particular disorders. Okay, so for the first disorder in this section, I want to talk a little about delirium. And you may have heard a little about delirium. You may have heard it be said that somebody's delirious. And so basically, when that term's used correctly, what that means is that there's a disturbance in attention and awareness. There's a reduction in ability to direct, focus, sustain, or shift attention, or it could be that there's a reduced orientation to the environment. And this delirium, it develops over a short period, could be a few hours, could be a couple of days, and it represents a change in previous functioning, a change from previous functioning, a change in baseline abilities. And the other interesting thing about delirium is that abilities can fluctuate throughout the day. So it could be that a person appears to be a lot more lucid and aware, and then they're not, and then they are again, and then maybe they're not, and so it fluctuates throughout the day. With delirium, there must be a cognitive disturbance present, and that would be a disturbance in memory, disorientation, could be a disturbance in language, a disturbance in perception, and again, visuospatial ability. And there needs to be evidence from history or a physical exam or lab findings that a disturbance is a direct physiological consequence of another medical condition, substance use, or toxin exposure. Now, there are several specifiers for delirium, and you would need to look into the DSM-5 for that. I'll refer you to that so that you can see the specifiers for delirium. Okay, so now we'll turn our attention to major neurocognitive disorders, and also want to bring your attention to the fact that the DSM divides neurocognitive disorders into major and mild categories. So for major neurocognitive disorders, there's evidence of significant cognitive decline from previous level of functioning. And of course, that would be complex attention, executive functioning, learning and memory, things of that nature. And objective testing is useful in making diagnoses for major neurocognitive disorders. Cognitive deficits interfere with independence and daily activities, and cognitive deficits do not occur exclusively in context of delirium. And so we have many subtypes of major neurocognitive disorders, and we can think of these subtypes in terms of their etiology. That's one of the things that helps us to, perhaps the only thing, I'm not sure about that, but certainly one of the things that would help us determine one disease from the other would be the etiology of each disease. The subtypes would include Alzheimer's disease, which I'm sure that all of you have heard about. You've also probably heard about traumatic brain injury, and maybe substance medication-induced disorders, neurocognitive disorders. Let's see, you've probably heard about Parkinson's disease and maybe Huntington's disease. Some of the ones that you may not have heard about is frontotemporal lobar degeneration, Lewy body disease, of course vascular disease. That's becoming more and more commonly heard of these days, especially as we begin to understand more about neurocognitive disorders, and we have advances in neuroscience and neuroscience technology. HIV infection, now there's an interesting one. I remember, I'll tell you just real briefly about a time many years ago. This has probably been, it's probably been 3 decades or more ago when I worked in a hospital. And I remember there was a person there at the hospital, a middle-aged person, that had HIV/AIDS. And I remember that over the period of a year or two, he would periodically show up in the hospital and be admitted. And I remember there were times when it seems like he would be doing pretty well, and then times when he wouldn't be doing well at all. But I could tell that over time his cognitive abilities were declining, and so I never did have access to his chart or inclination to look at it at that time, but I suspect that there was a neurocognitive disorder that was progressing with him as his HIV infection and AIDS worsened over time. And of course, back in those days, let's see, that would have been back in the 80s, probably the late 80s, early 90s. We didn't have the medication back then, as far as I understand, that we do now, that could delay illness from HIV infection. So, anyways, so with HIV infection, a major neurocognitive disorder can indeed develop. So moving on now to mild neurocognitive disorders. They are similar to major neurocognitive disorders, but there's a couple of exceptions. There's evidence of modest cognitive decline, so it's not major decline, and that these cognitive deficits in mild neurocognitive disorders do not interfere with interdependence. And so people with mild neurocognitive disorders can still function in terms of their activities of daily living and all that kind of thing. Now, the interesting thing here is that mild and major neurocognitive disorders occur on a continuum. And so obviously we know that some of the subtypes that I talked about a minute ago, subtypes of the major neurocognitive disorders, we know that some of those are, if not all of them, well, I guess all of them wouldn't be, like traumatic brain injury doesn't necessarily have to be, but a lot of these are progressive in nature. So for instance, I'm thinking about my family member. I had a family member with Alzheimer's, and I remember when his Alzheimer's first became apparent, he was generally forgetful, and it wasn't all that big of a deal. Just needed to have some cues sometimes to be reminded of things. And we all said, oh, well, he's getting older, and he's in his 70s, and some of that can be expected, some forgetfulness, and maybe a bit of decline in terms of memory and all that. And but over time, the forgetfulness worsened, and I remember one time I was sitting in his living room, and keep in mind, this is someone that I was very close with, that knew me quite well. And I remember one day he looked over at me and said, who are you? Wanted to know who I was and wanted to know why I was in his living room. At other times, he mistook me for a different family member. He would call me by my father's name and have conversations with me about things that he and my father had done at some point in time. And then of course it progressed to the point that he wasn't able to care for himself and eventually passed away from the Alzheimer's disease. And so again, they can be on a continuum of severity from mild to severe. So we'll talk about treatment outcomes just ever so briefly. One of the best things, apparently, that we can do for these kind of disorders has to do with prevention, trying to make a healthy living, engaging in mental exercises. There's apparently some suggestion that staying mentally fit can delay onset of some of these and progression of some of these disorders. So early detection is important. With appropriate intervention, it may shorten the duration of delirium, for example. Intervention certainly impedes disease progression. At least we, again, have some suggestion of that. The interesting thing about delirium is that the majority of people recover regardless of receiving treatment. Although some people don't recover, and I was reading in the DSM that people that are hospitalized with delirium tend to not do quite as well. And of course, we can make a lot out of that, and I don't know that there's any cause and effect relationship there. I would have to look into the research on that. But that's an interesting point because, as you know, the DSM, or at least I hope you know, the DSM is a very thick book, about like so, right? It's pretty thick. And there's lots and lots of information in there. And I want to remind you that that you don't need to know everything that's in that book. What you do need to be able to do is pick that book up and use it as a reference. So if you need to know about a particular disorder, you're able to look it up and read all that there is offered on that disorder in the DSM. And if you do that, you'll come away with a pretty good understanding of that particular disorder, assuming that we trust the validity and reliability of the DSM. Now, the other thing to do is to actually get into the literature and the database, which is exactly what I did yesterday. I was interested in learning something about a personality disorder, and the DSM can be pretty interesting about those types of disorders, and we'll actually talk about those in another lecture. But I spent some time doing some research on that disorder and looking in the social science databases and some of the research that's been done, and learned quite a few things that wasn't available in the DSM, which makes sense because the DSM is dated material. So even though our current DSM has only been out for a short while, comparatively speaking, in terms of DSM editions, there's new research out, that may have been published last month or maybe 6 months ago or a year ago that would be certainly more informed. So again, get the research literature so you'll know what you're doing. Now, there's also medication to delay disease progression. Aricept comes to mind, and I'm not sure that, I think Aricept, if I'm not mistaken, is prescribed for people with Alzheimer's disorder. But again, you need to look that up if you wanted to. The thing about these particular disorders is that I don't see in clinical settings, I don't see a whole lot of these types of disorders, especially for outpatient psychotherapy. My guess is that you would see a lot more of these in the neurology office if you were a neurologist, a medical doctor that specializes in neurology, or perhaps the mental hospitals. You might see some of these disorders, although I kind of doubt that as well, based on what we know about insurances and requirements to be hospitalized for any length of time. Okay, so again, I want to remind you that information from here is from the DSM, and other than that, study hard. You should have plenty of things to read. I'm constantly putting things on D2L for you guys and gals, and things that I think would be of interest and would help your learning experience. So, okay, I'll see you next time.